All right, welcome. Today we are tackling some of the toughest, high-stakes topics that are pretty much guaranteed to pop up on your exams: demyelinating and autoimmune disorders.
You know the feeling, right? You get a question about a patient with weakness or vision loss, and suddenly you're staring at this list of options that all sound the same. Being able to tell these apart under pressure is going to score you some seriously crucial marks. And the good news? There's a system to it.
So let's get right into it. We're going to give you one single clinical framework that is designed to help you master all of them. It actually mirrors how the people who write these exams build the questions in the first place. This is your key. So, this is it. One framework to take down 4 exam killers. This is the 3-step approach that's going to get you through any clinical vignette they throw at you. It's simple, it's repeatable, and trust me, it works when the clock is ticking.
Think about it like a real clinician would. First, you just ask, where's the problem? Is it in the brain and spinal cord, the central nervous system, or is it out in the nerves, the peripheral? Then, step 2, how fast did this happen? Are we talking acute, over a few days, or is this chronic, dragging on for weeks? And finally, the fun part. What's the one unique clue that cracks the case? Is it an antibody, a specific MRI finding, a weird CSF result? That's your key discriminator. Let's put it to work.
All right, let's apply our framework, starting with the central nervous system. And we've got to begin with 2 of the biggest mimics on any neurology exam: multiple sclerosis and NMOSD.
Okay, so for multiple sclerosis, or MS, the classic buzzwords you're going to see are dissemination in time and space. What does that even mean? It just means you're seeing evidence of damage happening in different parts of the CNS at different points in time. The classic picture is a young adult with neurological symptoms that just kind of come and go. But the absolute money shot on an MRI is these things called Dawson's fingers right around the ventricles, and you'll often see something called oligoclonal bands in the spinal fluid.
And here is a perfect example of how they'll test this. A young adult comes in with painful vision loss in just one eye, a relative afferent pupillary defect, that's the RAPD, and an MRI showing those periventricular lesions. What's the diagnosis? It's MS optic neuritis. You have to recognize that pattern instantly. Now, NMOSD. This is a totally different beast. You gotta understand this. It's not really a primary attack on the myelin sheath itself like an MS. Nope. It's an attack on these support cells called astrocytes, and it's driven by a specific antibody, AQP4, and because of that, the damage is way more severe, which is a massive clinical clue.
So, what are the red flags? What should you be looking for? Well, the attacks are just brutal. We're talking severe vision loss, often in both eyes, with really poor recovery. You need to look for this very specific kind of weird symptom called area postrema syndrome. That's uncontrollable hiccups or nausea. And this is a big one. On an MRI of the spine, you'll see a lesion that is long, spanning 3 or more vertebral segments. That's what we call longitudinally extensive transverse myelitis, or LETM for short.
Okay, this slide right here. This is your money slide. It lays out the highest yield differences, plain and simple. Look at the optic neuritis. One eye and good recovery in MS versus severe, often both eyes, and poor recovery in NMOSD. The spinal cord lesions, short in MS, long, that LETM, in NMOSD. This table is your cheat sheet.
All right, moving on. Let's talk about the great pretenders. 2 other CNS conditions that can really look like MS. We're talking about MOG, antibody-associated disease, or MOGAD, and ADEM.
So, MAGA can be tricky. It can look a lot like MS or even NMOSD. But here's the key differentiator for your exam. It's all about the steroids. These patients get way better on high-dose steroids, and here's the tell. The second you start to taper them off, bam, the symptoms come roaring back. That steroid dependency is a massive clue for MOGAD.
And then there's ADM, acute disseminated encephalomyelitis. For this one, there's one word you absolutely have to burn into your brain: encephalopathy. The patient isn't just weak or numb, they're confused, they're lethargic, maybe even in a stupor. This change in their mental status is the key thing that separates a classic ADM presentation, often in a kid after an infection, from a typical MS relapse.
Okay, let's switch gears. We're going to take our framework and apply it to the peripheral nervous system now. And we're going to focus on 2 big ones that are really separated by one simple but totally unbreakable rule.
This is it. This is the rule. It all comes down to time. If the weakness gets worse and worse for less than 8 weeks, you're looking at GBS. If that progression or a relapsing course goes on for more than 8 weeks, your diagnosis is CIDP. Seriously, it's that straightforward.
So when you see a patient with weakness that starts in the feet and moves up, and you check their reflexes and they're just gone, especially if they just had some stomach bug or a cold, you have to be thinking GBS. The keywords are areflexia and ascending paralysis. And clinically, the most important thing is to watch their breathing, usually by checking their forced vital capacity, or FVC, because respiratory failure is the #1 threat.
And here it is. This is one of the biggest exam traps, so listen up. Steroids do not work for classic GBS. Unlike pretty much everything else we're talking about today, giving steroids is the wrong answer. The correct answer for treatment will always be IVIG or plasmapheresis. Don't fall for it. Okay, last big category. Let's talk about a high-yield mimic that's not really a demyelinating disorder, but often gets confused with them because it's autoimmune. And this one presents in a really different way, often starting with psychiatric symptoms, autoimmune encephalitis. So if you get a vignette about a younger person who over just a few days or weeks suddenly develops psychosis, new seizures, and serious memory problems, your alarm bell should be screaming autoimmune encephalitis. Don't just write it off as a primary psychiatric problem. The next step is to look for specific antibodies like anti-NMDA and get them started on immunotherapy early.
Awesome! You guys are doing great. Now, to make sure all of this sticks, let's do a quick lightning round of the most common exam traps and lock in those final anchor points.
Trap number 1. You see LETM, that long lesion spanning 3 or more segments, on an MRI report. Your brain should immediately pivot away from MS and start thinking NMOSD or MAGA.
Next trap, area postrema syndrome. Those crazy, nonstop hiccups and that intractable nausea, that is a powerful, specific clue pointing you straight to NMOSD.
And this one is so common, a pseudo-relapse. If an MS patient gets worse, but they also have a fever from a UTI or some other infection, it's probably not a true relapse. There's no new inflammation going on. The right answer is to treat the trigger, treat the infection, not blast them with steroids.
All right, let's lock in these final anchors one last time. 1. MS equals dissemination in time and space. 2. NMOSD equals that long cord lesion, LETM, plus the AQP4 antibody. And 3. GBS is acute weakness with absolutely no reflexes. So remember the framework. Localize the lesion, define the time course, find the key discriminator. You use that and you're going to be ready for any of these vignettes they can possibly throw at you.